Thank you so much, John, and thank you for the invitation. I'm really honored to be here. I don't know which is more difficult, to debate Dr. Andy Zelnitz or to follow Drs. Bartlett and the case on the podium, as they're such remarkable speakers. So my first talk will be delivered by Dr. Matthew Haberman, that's my middle name, and my second talk will be delivered by Dr. Thomas Haberman, and that's the doubter. And so with that, we will start. So these are my disclosures. I will be talking about off-label disclosures, and they're listed there in their companies, and this will suffice. These are other disclosures, and I really couldn't stand up here without having, in my career, been involved in the cooperative group systems and our SPORE and other things, and a number of people in the room have participated in so many ways. So to take both of these topics, and this talk I started at 2:30 yesterday morning and worked on the plane. I'm going to list 4 things I'd like to cover for the yes side of maintenance therapy. And so, first question is, why is this even important? Large cell lymphoma is the most common lymphoma, and there are fiscal issues. And this data comes from the North American Association of Cancer Registries, which looks at subtype incidence and survival. 112,000 patients, and large cell lymphoma comprised 25% of those. And that's just been published. So this is probably the best incidence data. So the first lines of evidence suggest that the progression-free survival and the event-free survival are improved with maintenance rituximab in a meta-analysis of maintenance rituximab, which included 5 randomized clinical trials. And this paper has just come out, but rather than go through the trials individually, I thought this actually provided a pretty succinct way to look at it. Some of us in the room have witnessed all of these trials. The beginning of the rituximab era was in the very early 90s, and there are all kinds of strategies to improve on CHOP. Then it became R-CHOP, really the first regimen in 25 years to improve overall survival. And we went through all of these things nationally and internationally, and we all had some great ideas. We looked at dose intensity to no end, transplant strategies, and so forth. And then there were 5 different publications looking at rituximab maintenance, and this was put together in this meta-analysis. And you can see that the numbers of patients included in these were 152 up to 662 patients. The settings, the large cell was in each one, but there's a little bit of mix there. The Giselbrecht was relapse refractory, and in the Jaeger trial, follicular grade 3 was included, and some of those patients weren't initially randomized. And the Herrig publication had all 3 untreated, relapse, and refractory. And you can see the follow-up on the far end. The range is 32 to 48 months, and the endpoints were failure-free survival or event-free survival or relapse-free survival in all, and then overall survival in 4 of the 5. And they used the Cochrane handbook. They looked at the 5 clinical trials I've just outlined, and they reported an improved progression-free and event-free survival with maintenance rituximab. So when you look at this data a little further, it's interesting that males had an improved event-free survival, and the hazard ratio was 0.53 in a meta-analysis, but the overall survival wasn't improved. And so looking at the Giselbrecht trial, we all remember when that came out, men that were involved in the field, women did better than men, 70% versus 38%, and that p-value is quite significant. We don't quite, in the publication itself, the original one didn't have exactly what each got and how those played out with regard to the maintenance rituximab. It was just women. Then the overall survival was improved also at 76% versus 50%, and that's a pretty significant p-value. In the Jaeger trial, male patients did better, and when they combined the Jaeger and Herrig, there was an improved overall survival. They went on further to look at some sensitivity analysis data, and there was low heterogeneity when the Gieselbrecht study was excluded. And so the event-free survival in untreated was hazard ratio 0.75 versus relapse 0.93. So, and I think we would anticipate those. And however you looked at it, there was no difference in the overall survival. And so the next trial is the REMARC study, and I'm sorry I don't have the, I think this is the previous, my earlier slides today, and not the, and this comes back. Oh no, here it is. I'm sorry, the next trial is the REMARC study. And in this study, patients received 6 to 8 cycles of R-CHOP, and then were randomized in a 1-to-1 randomization to lenalidomide for 24 months at a dose of 25 milligrams per day for 21 of 28 days. So that's full dose lenalidomide, actually, as we first reported in the first phase 2 relapse refractory study in the JCO in 2008. And these patients were aged 60 to 80 in follicular grade 3B, and you had to be in a CR or PR to get randomized. So these are the results that just came out at ASH. The median progression-free survival was not reached with lenalidomide, but with placebo was 68 months with the hazard ratio of 0.01, or p-value, I'm sorry, of 0.0135. The CR to PRs, 21%, but interestingly in the placebo group it was 14%. And I think for all of us involved in clinical trials, another really fascinating piece of this abstract and presentation were that in the lenalidomide group, 59% of patients had drug discontinued, but in the placebo group, 40% had drug discontinued. Now, that's really fascinating, and that sometimes, you know, there's a history of carrier molecules. For instance, a drug called anagrelide initially had some diarrhea problems, and it turned out that it was related to some of the carrier compounds and so forth, and once that was cleaned up, that went away, but this isn't the 40% number we're looking at here. Dose adjustments, 72% and 42%, and there was no significant difference in the overall survival. CTs were performed in this study. And so this was the overall survival curve. There was no statistical significant difference. What is interesting is that when then looking at cell of origin, the data looks a little different. So in the ABC and unclassified, there's no difference, but there's a fascinating trend in the upper right curve showing the p-value to be 0.07 and difference in patients receiving lenalidomide. And I'll explain that. I'll comment on this a little in the second talk. So these are the 4 questions I presented to you, or topics. The man in the middle was the founder of Mayo Clinic, and he said no one's big enough to be independent of others. Probably no more truthful thing I've read, and I couldn't stand up here without being part of the group, and I appreciate all your attention, the industry support, John and Lauren Balwell's, and all the patients that have participated. Thank you.